Oh, I'm live. After all the training and support and preparation, I missed the beginning and I'm really sorry. Welcome everyone to the webinar, the first of three, this one on post-traumatic stress disorder, complex trauma and substance abuse. Some promising new treatments for adolescents. We're really delighted to have you all here today and welcome to the first of these. I'm Leanne Beagley. I'm the CEO of Mental Health Australia. If you don't know what that is, it's the peak national non-government organisation representing and promoting the interests of the Australian mental health sector. And I'm delighted and honoured to be chairing today. I'd like to begin by acknowledging the traditional custodians of the country throughout Australia and their connections to land, sea and community. We'll all be paying our respects to the elders past, present and emerging, and extend that respect to all First Nations people and Torres Strait Islander people today. Kia ora to those joining us from New Zealand, and also like to take a moment to acknowledge those with lived experience of mental illness and trauma, especially where they've shared their stories to help us all better understand. We thank you. Before we get straight into the session, I'd just like to remind everyone that if at any time you're feeling distressed, please do seek support. In Australia, THEMS suggests contacting Lifeline on 13 11 14 or Blue Knot Foundation on 1300 657 380, and in New Zealand, a free call or a text 1737. Delighted to be introducing two evidence-based research presentations from the Matilda Centre. Plus, we'll also get to hear from a lived experience perspective and from a clinical psychologist. So we've got a packed hour. If you've got questions you'd like to ask any of the speakers in the light of the topic or the content that you hear, please submit your question directly in the Q&A part of the portal, which is located on the right-hand side. Just a note that your questions won't be visible to other people, and I'll ask them on your behalf. Please also note that the email addresses of all the speakers will be made available to you, so that if you want to just ask them questions directly, you can do that after the webinar. All right, well, now let's get straight into it. I'd like now to introduce our first speaker, Senior Research Fellow and Director of Early Intervention and Treatment at the Matilda Centre, Catherine Mills. Catherine, thank you, and over to you.
Thanks, Leanne. Just pop my slides up. Hopefully they're okay there. Yeah, good afternoon, everyone, and thanks for coming to the webinar this afternoon, which I'm really delighted to be a part of, and the discussion as well. I'd also like to start by acknowledging the traditional custodians of the lands we're meeting on today, which for me in Sydney is the Gadigal people of the Eora Nation. I pay my respects to elders past, present and future, and would also like to acknowledge and pay my respects to people with lived experience of trauma, substance use or mental health conditions. Sorry, too far ahead. Just to start with though, around trauma, it's a term that is really commonly used, but also very broadly by people when referring to a range of things, from something that might have happened that's mildly distressing all the way through to really horrific life-threatening events. But when I'm talking about trauma today, I'm particularly talking about either single events or a series of events that a person experiences or witnesses where they perceive that their safety might be at risk, or the safety of someone else might be at risk. Our most recent estimates in Australia of how common trauma exposure is tell us that most of us will experience a traumatic event at some point in our lives. And among those who do, most will experience the first one in childhood, and most will also experience multiple traumas. Although men and women in Australia are equally as likely to experience traumatic events, the types of traumas tend to vary. So men are more likely, for example, than women to experience events where they experience or witness or perpetrate violence, or also be in accidents, whereas women are more likely to experience domestic or sexual violence. But regardless of the type of trauma, or whether it's a one-off event or something that's more prolonged, they're typically profound life-changing events that can really redefine the way a person sees themselves, the world around them, and how they interact with it. And for those who are unfortunate enough to have experienced trauma during childhood, those beliefs can become particularly well entrenched. And the consequences can be really broad and also potentially long lasting, um, impacting on a diverse range of areas of life, including someone's education, their employment, their ability to form and maintain relationships, and also whether or not they might go on to engage in some risk taking behaviors or experience aggression, but also the development of substance use or mental health disorders. Because childhood trauma has consistently been found to have a strong and enduring association with all classes of mental health disorder across the lifespan and around the world. With regard to substance use specifically, um, childhood trauma and adversity has been associated with increased rates of alcohol abuse and illicit drug use, an earlier age of onset of use, as well as poorer mental health and higher rates of attempted suicide. And there's also a dose response relationship that's been observed, whereby the risk of any of those outcomes happening and the severity of those outcomes is increased with the number of adverse events experienced. So, for example, as I have on screen there, for each additional event experience, the odds of developing an illicit drug problem can increase by between 30 and 40%. And our own data, population level data in Australia, has shown us that 1 in 3 adults who reported experiencing child or adolescent trauma have gone on to develop a substance use disorder, or what has previously been known as abuse and dependence. And that's a rate that is 3 times that of adults who've never experienced a traumatic event, and 1.3 times higher than that of people who have experienced trauma but only in adulthood. But interestingly, the development of substance use disorders following trauma is typically mediated through the development of other conditions such as post traumatic stress disorder. So, by that I mean that it's not necessarily the experience of the trauma itself that can lead to increases in potentially problematic substance use, but rather the problems that a person develops as a result of the trauma that can increase the risk of problematic substance use. And post traumatic stress disorder is one of the most common mental health conditions to develop following exposure to trauma, but also the one that can most easily be attributed directly back to a specific event. But that affects about 1 in 10 Australians who've experienced trauma. Many of you will be familiar with the condition, so I won't go into detail on the symptoms that are on the slide there. But I will just say to remember that it is an adaptive response to fear that has become maladaptive. So responses that, in the presence of a potential threat, can actually keep you safe. But it becomes problematic when that alarm is being activated or set off in situations where there is no threat, and where it starts to impede on a person's the way they want to live their life and their functioning. In Australia, 65% of men with PTSD and a third of women also have a co-occurring substance use disorder. And some more recent analysis has also shown that the odds of a person transitioning from just using substances through to developing a use disorder are increased in the presence of post traumatic stress disorder. Some people, as well, around approximately half of people with PTSD may actually also be experiencing a more complex form of that, characterized by difficulties in affect regulation, having persistent negative beliefs about themselves, and disturbances in their relationships. And while this is typically associated with childhood and repeated interpersonal traumas. It can come about as the result of any trauma type. And while, I mean, the good news is 92% of people who do develop PTSD achieve full remission, so no symptoms at some point in their life. But it takes an average of 14 years. And for more than a third of people, they will continue to have symptoms for more than 30 years, which is really why we want to be able to get in and intervene early. For many people, self medication can play a critical role in either the development or the maintenance of a substance use disorder. So, for example, the self medication hypothesis postulates that a person develops a substance use disorder after experiencing trauma as a consequence of repeated use to try and ameliorate their PTSD symptoms. And it's kind of similar to what I said about PTSD earlier, about it being an adaptive response. It's an attempt to cope, but through that repeated use, it can become a maladaptive response. And there is, in support of that, it's also, you can certainly see that for 2/3 of men and for half of women, the development of PTSD as a condition typically precedes them developing an actual substance use disorder. But there are other theories as well as to why they commonly co-occur. Another one is the high risk hypothesis, which puts forward that people who use a lot of substances, particularly illicit substance use, sometimes have a lifestyle that puts them more at risk of experiencing trauma, hence more likely to develop PTSD. Um, there's also a susceptibility hypothesis, uh, which states that people with substance use disorders possibly lack the coping skills needed to deal with the trauma when it happens, and therefore might be more likely to develop PTSD. But there's also a physiological um, susceptibility as well in relation to this, in that potentially the repeated patterns of intoxication and withdrawal are thought to potentially sort of prime the stress response system to have a dysregulated response to trauma, therefore increasing the likelihood of developing PTSD. And as with all co-occurring conditions, the common factors hypothesis, there may be any number of common biological, psychological, or sociological factors underpinning both that make them more likely to co-occur. But regardless of how they come about, once a person does have both a substance use disorder and PTSD or other trauma-related disorders, each of those can serve to maintain and exacerbate each other. We also know that studies that have looked at changes in symptoms of one disorder and the impact that it can have on symptoms of another have shown that these conditions are really integrally linked. So improvements in PTSD symptoms will often lead to improvements in substance use. But the reciprocal relationship is not typically observed, and certainly not as strongly. PTSD symptoms don't tend to remit even following substantive, if there were improvements in substance use. And what more often tends to happen is that if a person starts to reduce their substance use or stops using, they might find that their PTSD symptoms actually increase, particularly if it has served some self-medication function. But that can make it really difficult for people to either maintain controlled use or maintain abstinence, and really highlights the centrality of why we need to be addressing trauma and PTSD for people if they are seeking help for their substance use. And again, why we need to intervene early, hopefully before these things become well established and mutually maintaining conditions. But many clinicians in Australia and internationally also report that they find this a particular challenge of not knowing how to best approach this with clients. And historically, there has certainly been some reluctance to address trauma and PTSD among people who are also having issues with substance use. And But that reluctance has come from a good place, essentially, in that people have been worried about doing the wrong thing. In particular, they've been concerned about, is this a population group who might be too vulnerable to address the trauma, may need to address the substance use first, um, for fear of, will people deteriorate either in relation to their substance use or in any other way. Because of that, what you typically see is people adopting a sequential model of care, whereby they try to get people to reduce their substance use, but more often than not, try and get them to abstain from use, potentially for long periods of time, before addressing the trauma. As I mentioned previously, though, when people try to do that, they often find that their PTSD symptoms increase, making it really difficult. So often they may not ever get to do the PTSD treatment part, and just end up falling between the cracks. Because of that, more and more research has been focusing on integrated treatment models, so treating the substance use and the PTSD at the same time by the same clinician. And there's a growing number of studies that have examined integrated treatments. How can we address trauma safely and effectively when there are substance use issues? And existing approaches have been divided into two main types. One, present-centered or non-trauma focused therapies that focus on coping with the current symptoms, whatever a person might have, but doesn't delve back into the past trauma experiences themselves. Past or trauma focused therapies, on the other hand, do involve a person delving into and processing what happened to them by tackling it pretty head on. Those are typically delivered individually and include the use of exposure based techniques in which the client is exposed to reminders of the trauma, including their traumatic memories, as well as things that may physically remind them of the events that have happened. But very importantly, it is only done in terms of safe situations and by therapists who are well trained in the technique. Exposure therapies have long been considered one of the gold standard treatments for PTSD, and support of these types of integrated programs that include these approaches is growing, with an increasing number of studies providing evidence for their both safety and efficacy. Not only do they not make people worse, they actually produce improvements. There have been two actually large randomized controlled trials, or large for this field, conducted in Australia, both by our research group at the time. But most of these studies to date have focused on adults. There are very few treatments examining adolescents or younger populations. And until very recently, they tended to focus, or they were really small pilot studies that were promising, but with inconclusive findings. But it was just last year that results were published of a randomized controlled trial, which is at the bottom of the table there, that actually also included some form of exposure therapy. And it has very promising findings, but still options remain fairly limited, and we do need more research in this area. For all of the reasons I mentioned, it's clear that we need to be intervening earlier, but we need that evidence base to be able to help guide clinicians as to how to best do that, and also so that there is a range of options available to clients who may prefer different types of approaches. To address this evidence gap, we also sought funds to undertake a trial of an integrated treatment designed to meet the needs of younger people, and that's based on an intervention that's shown to be efficacious among adults. So the treatment is called concurrent treatment of PTSD and substance use disorders using prolonged exposure, or COPE. And it basically integrates best practice approaches of cognitive behavioral therapy for substance use disorder and cognitive behavioral therapy for PTSD, incorporating exposure-based techniques. And in collaboration with other colleagues at the Medical University of South Carolina, we conducted the first randomized controlled trial of this therapy internationally, more than a decade ago now, among over 100 Australian adults who had quite a severe clinical presentation. They were all substance dependent, used an average of 4 different drug classes, most commonly heroin, cannabis, amphetamines, and benzos. 75% had experienced their first trauma in childhood, with an average age of 8 for the first. Their PTSD symptoms were chronic. On average, they'd been experiencing them for about 10 years, but it ranged from up to 40 years. They also tended to be severe symptoms, yet very few had actually ever accessed treatment. Despite that clinical profile, we did find that the intervention was able to achieve significant reductions in PTSD symptom severity, and that was accompanied by reductions in severity of substance use disorder. And we also got quite a lot of very positive feedback from clients about how the treatment had helped them. And while some of that exposure stuff, going back and confronting what had happened to them, was very hard, that often they found that to be the most useful aspect of the therapy. And since that study, there have been several more studies conducted in the US and Sweden, making this particular treatment type the most researched to date. And there are also 2 implementation studies being conducted in real world clinical settings at the moment in northern New South Wales and in Melbourne. But we're currently conducting the first trial to examine the efficacy of this treatment that's been adapted to be used among younger people between 12 and 25, which we're doing in Sydney at the moment. But with that, I will hand over to Ash to tell you a bit more about that. Thanks.
Thank you so much, Catherine, and thank you for some really classy research navigation for us. Handing over to Ash now, who is the Aisling Isaac, her name is, clinical psychologist at the Matilda Centre, currently working on a clinical trial and bringing this very contemporary feedback to us. Thanks, Ash.
Thanks, Leanne. Just pull my slides up here. Beautiful. So thanks, Kath, for your presentation as well, and hi to everyone listening. My name is Aisling. I'm a clinical psychologist and I'm working on the COPE trial. So as Kath mentioned, COPE is a clinical trial for combined treatment of post-traumatic stress and substance use in young people. And so this is one of the examples of emerging research into treatments for young people. It's still in the very early research stages. So today I'll give a short presentation from a clinical perspective within research. So my role as a psychologist in this program is to deliver the treatment to young people. So today I'll give an overview of the treatment program and give you an idea of some of the clinical presentations we get, and I'll run through a case study at the end. So Kath has already presented a lot on the research background, so I won't go too much into it, but from these studies we can see that trauma exposure is very prevalent in young people, and in adolescence, PTSD and problems with alcohol and drug use tend to co-occur together frequently. This slide here highlights the need for early intervention. So we know that early trauma is associated with an increased risk of serious and disruptive problems across a range of domains that can persist into adulthood. And research has shown that the earlier the trauma and the greater the exposure to trauma, the greater the risk of impairment for young people. And Kath has touched on this already again, but there are quite significant harms associated with co-occurring PTSD and substance use in young people. And the clinical severity of this profile as well can go on to impact how effective treatments are. So COPE, this trial was developed with the aim to treat substance use and traumatic stress in adolescents specifically. It was developed in response to a critical need for early intervention and also in response to a lack of empirically validated treatments for young people presenting with this presentation. COPE is an NHMRC-funded randomised controlled trial. It was designed to examine the efficacy of a combined treatment program for co-occurring PTSD and substance use disorders in young people aged 12 to 25. And COPE is an adaptation of the adult treatment manual COPE, which Kath mentioned earlier, which was published in 2012. And this trial is an RCT. So for anyone who's not familiar with that, means it's looking at the efficacy of copay in reducing PTSD and substance use symptoms in young people compared with the supportive counselling control. So I'll talk a little bit about the recruitment process in our study. We get most of our referrals from health and social services, including hospitals, headspaces, and we get a fair few participants self-referring as well. All participants are screened in person to see if they meet eligibility criteria. And to meet criteria, participants have to be 12 to 25, experienced one trauma in their lifetime at least. They have to meet DSM-5 criteria for PTSD, and they also have to have used alcohol or other drugs in the last month and have a history of problematic use. We have some exclusion criteria, which includes a current high risk of harm, active psychosis, or other things like ongoing trauma-related threat. So if this is the case, usually we will refer clients to a more suitable service until things have stabilised for them. So this is an idea of what the treatment program looks like. After participants are screened, they are allocated into either copay treatment or into the supportive counselling arm. So copay is a manualised treatment. It's delivered over 12 to 16 sessions. Sessions are delivered weekly and they are 60 to 90 minutes each. So the 4 extra sessions just give a bit of buffer room. The initial sessions at the top are focused on rapport building, psychoeducation, goal setting, motivational interviewing. So this is all designed to increase the client's engagement with the program and to develop that therapeutic rapport. And then the bulk of the treatment goes into basically behavioural and imaginal exposure to treat PTSD symptoms, and also looking at CBT to address substance use disorder. And then towards the end, we focus on relapse prevention, and we might provide referrals to other services if it continues to be needed or if the client wants it. So to give you an idea of what the control treatment arm looks like, we use a supportive counselling called person-centred therapy. So this has the same session structure of weekly counselling up to 16 sessions. And the initial stages of therapy are pretty similar, so focuses on rapport building and goal setting. However, this approach uses a non-directive and reflective style. It doesn't go into any cognitive or behavioural strategies, doesn't provide any psychoeducation, and doesn't do any exposure treatment. So to maybe highlight the difference between the two treatment arms, if a client was in therapy to ask, how can I cut back on my drinking? If they were in copay, we might go through some strategies and really workshop that. But if they were in this person-centered therapy, we might reflect the question back onto them and see if they can generate some answers themselves. So I'll run through now a snapshot of the clinical presentation of the sample we have in our trial. So all this data is analysed from the baseline data that we collect before clients start treatment. And this was all analysed last year, so we had 26 participants at the time. So that number's increased, so this data will probably change, but just to give you an idea. So the average age was 17 with a big range. Most participants were female, most born in Australia. 36% were attending school or enrolled at school at time of treatment, but all the participants who were at school reported a low attendance rate, on average 75%. 61% had been suspended from school at least once, and about a third were in TAFE, uni and or in employment. There's some overlap there. And then looking at some of the social problems down the bottom, over a third reported that they had been arrested at least once, 11% had been in juvenile detention, and 42% reported at some point in their lives they were without a stable home. In terms of trauma, the most commonly reported trauma was witnessing or hearing of violence or physical abuse. That was followed by experiencing sexual assault or other forms of sexual abuse, and then followed by experiencing or being threatened with physical assault. So the majority of participants had experienced multiple or prolonged rather than single incident trauma. And most met criteria for a full diagnosis. Most participants reported comorbid, other difficulties, mood disorders, other anxiety disorders, things like that. In terms of substance use, so we get participants to note down their drug of most concern that they want to work on. So this was predominantly cannabis, followed by alcohol. On average, participants had used 4.7 different drugs in the past month and 9.6 different drugs in their lifetime. So that question there was taken from the substance use motivation scale. The primary reported motivation for using substances was to cope with anxiety and depression. So that was self-reported from our sample. And if we look down the bottom at risk, you can see that even though they might not be current risk, it's quite a high risk presentation in the sample. So this gives us an idea or a sense of the sample that we are working with in the trial, which includes some quite confronting numbers, but we also collect some post-treatment data, so hoping to see some improvements in symptoms post-treatment. So where we're up to at the moment, we've allocated 38 participants. There are 5 currently who are in the study, and we're still continuing with recruitment, so we're welcoming any appropriate referrals, and a link for referring will be at the end if anyone's in Sydney and this is relevant to them. So I'll finish up today with a case study. So Sarah is a client that I'm currently working with. That's not her real name. And we're about halfway through the program. So Sarah is in her late teens and she was referred by a caseworker at a youth refuge that she was staying at. She had a long history of seeing mental health professionals, but she'd never received any specific treatment for substance use or PTSD. Her main drug of concern was alcohol. At presentation, she was drinking up to 12 standard drinks up to 4 times a week. Her PTSD symptoms included hypervigilance. She was getting really frequent flashbacks and nightmares 5 times a night, and her sleep, appetite, and concentration were all affected. She said she was using alcohol basically to escape or to numb her emotions, and that she was withdrawing socially, spending a lot of time isolated in her home and avoiding going out in public. Sarah also said she had experienced a lot of episodes of psychosis in the past. She believed this was linked with using particular substances like cannabis and MDMA. So at the time of starting treatment, this was all stabilized, and she didn't have any active symptoms, but we linked her in with a external early psychosis service who she's been seeing alongside doing our program. So Sarah had experienced very severe and prolonged trauma since she was very young. She reported experiencing physical, emotional, and sexual abuse from her parents, who she has little to no contact with now. She said she'd always lived in this state of instability, moving from refuges to temporary houses, and she's found it really hard to maintain work or to engage with study. So index trauma is what we refer to as the trauma that participants want to focus on in the treatment. So what she wanted to focus on was 2 incidents of sexual assault that had occurred recently, rather than focusing on childhood trauma. So that was her choice. So going through an example of how we might do the COPE treatment with Sarah. Sessions 1 to 3 were really focused on building that trust and rapport, going through some psychoeducation about PTSD and substance use, and getting Sarah to generate her own goals for therapy. So, for example, she chose abstinence as a goal, and she wanted to reduce her PTSD symptoms so that she could study and work. And we've now moved into the middle part of treatment. So we've set up some behavioural experiments. This includes like walking around to a suburb, catching a train, and we've also started on imaginal exposure of the trauma memories. So we do a debrief at the end and some cognitive challenging. So this has involved challenging some of the beliefs that have emerged for her following the trauma. So, for example, a lot of beliefs around self-blame. And we've also been focusing on CBT for substance use. As an example, Sarah's decided not to keep alcohol in her house, as that's a big trigger for her to be using. So we're up to about session 8 together, and she's engaging really well, and we'll soon move into relapse prevention. So that's all from me. Thank you for listening. I hope that was helpful to give you an idea of what an emerging treatment might look like in a research context. And I've put a link to our website there if you'd like any more information, or if you'd like to get in touch. Thanks very much.
Thank you very much, Ash and Catherine. Research and trauma and substance use in the adolescent space is obviously newer, and there's a lot to reflect on and discuss. And people also need to be aware that the presentations will be made available to those who've registered today. So that's great, because there's some really important links and references in those presentations that I think will be very useful for people. We do have one question from the audience that Catherine and Ash might like to take on notice and have a think about while we listen to the next couple of speakers. The question is about exposure therapy. Tell us more about the exposure therapy process, please. So we might come back to that. But firstly, I'd really like to introduce and invite our other speakers. So firstly, Kirsten Lee, who has lived experience in both complex trauma and substance use, and is now using her own recovery to help others through their own healing process. It's an absolute honour to have you with us, Kirsten. And also Sophie Reed, who's the co-director of Birch Tree Centre of Excellence and is a clinical psychologist with 20 years of experience. So welcome to you both, Kirsten and Sophie. Let me see whether you're up on the screen and it's all working. All right, so I might ask you a couple of questions to get you going. It's great to have you. Firstly, to Kirsten, perhaps reflecting on your own experience of recovery from trauma and substance use, what aspects of therapy have you found to be most helpful and also least helpful?
Oh, that's a great question. It's hard to make succinct, but I'll try. Basically, I found it really helpful, the rapport building. I hadn't had such effective rapport building before, especially around feeling a sense of trust around similar issues, being a feminist, having an LGBTIQA friendly space, and being pro 12-step. I'm 21 years sober in AA, so there are some people out there I experience negative responses to being in 12-step before, and just having that openness and acceptance of something that was already working for me was really helpful, and that I was already clean and sober to begin the work on the PTSD, and then having a therapist that's constantly updating. She's so on top of the most recent research and developments in trauma healing, and I think that being a circular dynamic with having client-centered and tailored focus as well, and modeling a really beautiful boundaried healthy relationship over time. Definitely that's been really helpful.
Thanks, Kirsten. And looking back at your 15-year-old self, what were some of the challenges and obstacles for you when you first became engaged with therapy or thought about therapy?
I guess, it was about a few decades ago. So, around the time I was 15, I was in an adolescent psychiatric unit. And I guess the attitudes at the time were, especially from people around me, my parents, other counsellors, was almost like it's your fault, and prescribing me with medication for, so many different things like depression, ADHD, all these different things. And no one actually asked me what's happening, like what is there trauma going on at home? No one asked the magic question. So it was almost blaming me, saying there's something wrong with you, let's medicate it. So that was the problem, I think, for me.
Yeah, so that must make establishing rapport, which is what we saw as the top of our kind of list of tasks at the beginning of the module in the co-pay program that Ash talked about, that establishing rapport would be really hard if people are not asking you the right question. Is that right?
Absolutely. I think, and with Sophie, constantly it's a beautiful dialogue where I feel really heard, really listened to, and I feel like she really understands, where I'm coming from, and has been open to hearing my story. And I feel that trust has been built, because obviously with trauma, it's something that's really hard to talk about, and I'm not going to just tell anybody. So building that rapport first is essential, I think. Yeah.
Thank you. Thanks. I'm going to come back to you in a minute, Kirsten, and jump to Sophie.
Hi.
Hi, Sophie.
I'm really good.
It would be great to hear what role you think that sort of therapeutic relationship plays And, you know, what does an effective therapeutic relationship look like? I think that Kirsten is telling us that's there for her. What, you know, from your perspective, how do you build that?
I think no therapy can happen without a good therapeutic relationship. And so, well, let me say particularly in this space in terms of trauma. So most traumas are of an interpersonal nature. And so if the therapeutic relationship doesn't have a good, steady, dependable, trustworthy style to it, then a client can't kind of settle and have the courage, which so many of our clients do, to go back in time and look at the traumas and see what's actually occurred. And so really what our clients are really relying on us as clinicians to do is to provide the kind of safety, the holding and containing of the space, and to provide the foot in the present moment so our clients can do that expositional work in terms of walking backwards through the past. And so a lot of that exposure therapy is about one foot in the present. I know where I am today. So for us, for me and Kirsten, it's about, you know, Sophie's office and, you know, we know where that is in town and those sorts of things. Whilst another part of Kirsten is allowing her mind to think about the previous experience. A flashback is when somebody really loses today and goes into that previous experience and feels like they've lost connection with their current moment self. And so, you know, in terms of that therapeutic relationship, my role is to really give Kirsten the anchor that I will keep her in the present moment while she allows herself to think backwards.
Thank you. Do you think that sounds like a complicated process? And it's obviously important and based on good engagement and good trust. Is it possible to do it on a short-term basis? Is it possible to do short-term interventions with young people who've experienced trauma?
I think that I like to think about, you know, we have a lifelong journey, all of us, in our, you know, for some of us longer, you know, hopefully as long as possible for all of us. And that sometimes you're doing small chapters of therapeutic work with people. And so one small chapter, I mean, I really acknowledge both Aisling and Kath both said that for the young people who are currently in danger, they weren't appropriate for that COPE study. So if you're currently in danger, you have absolutely no reason to start to perceive the world as safe, because you need to perceive the world as dangerous to be able to keep yourself in safety continuously. So when young people are actually in a safe enough kind of zone, then they are more likely to settle and do that, you know, therapeutic rapport and then do the work with you. And it might be that you're doing this really key critical moment where you get their drug use from here, which is leading to all sorts of disaster in their relationships, down to here, and you get some of those PTSD reactivity, sympathetic nervous system arousal from here down to here, which then allows them to move forward in life and maybe stay engaged at TAFE, keep their job, maybe not punch out the next policeman who walks past them, all of those things which actually lead to a better life. And maybe, you know, later in life, because what I find is that people don't really want to go near that really early childhood trauma until their life is quite stable. And there's quite a lot of research to support this. And Judy Herman, who's the, you know, the guru of trauma, talks about this, that it's not really until you're in your 30s and if you've got your life okay enough that it feels safe enough to go back to that childhood work, because you don't want to destabilize your life by going and doing that work. So it made sense to me with the case study that Aisling talked about, that young person wanted to talk about the more recent traumas rather than the early stuff.
Yes. And just one last question for you, Sophie, really about we heard how important the emerging evidence is around treating co-occurring trauma and substance use at the same time. Where does a young person's family fit into that kind of approach, that kind of integrated approach?
To be really honest, I think because I started my clinical work as a child and adolescent psychologist, and now I work mostly with adults about their childhood trauma. But I think about families as sort of, you know, there's a family system, and if the trauma didn't occur within that family system, and there is secure or good enough attachment, then that is an excellent position. And if you think about that, that might be medical traumas, that might be abuse outside of the home, where the family can actually wrap their arms around that young person and support them through their therapeutic process. So that's kind of one family system. And that's where, in the clinical work we do, we really assign one person to work with the parents and one person to work with the individual, so that someone's really holding the parents' fear and distress about what's happened to their dear one, their little one, while we work with their young person around trying to help their symptomatology so that we can calm the parents down so they can wrap their arms around their child. So that's kind of like, that's an ideal family system in this space. But then we've got the other sort of family systems where young people actually have experienced the abuse within the home. And really the safest place there is for the child to be out of that home if that abuse won't stop. And if we can't get, now in New South Wales DCJ, but if we can't get the intervention because maybe it's not at an elevated level or the young person is too old, so over 16, we don't get a lot of traction with reporting. Really, some of the things that I work with young people on are around, have you thought about going to university interstate, or have you thought about going and doing a TAFE course, or, you know, I've got one young woman who's talking about jillarooing, for example, to kind of get out of that family home, just so that we can get her into a safer space. So I think it's really around evaluating the resources of the family system as to their capacity to support
Sophie,
the young
thank
person.
you. That's fantastic. Can I just go back to Kirsten before we go to the researchers? Kirsten, what would you say is an effective treatment program for young people? What would it look like to you?
I guess exactly what I've experienced with Sophie, which is developing a really strong,
There's a mutual love.
I wanted to tell a story of, one time where Sophie accidentally double booked our session and how much of I was like, I'm not coming anymore. And that's my usual MO. And she just was so great. She set the first example for me of really beautiful amends and just said, look, I found a regular spot for you because I wasn't on a regular spot yet. And she made a space for me, and forever I've got a regular spot now. So modeling healthy relationship, making amends, attachment, healthy attachment for me is really important for young childhood trauma, and I've learned so many skills from that. But the rapport first, and part of that is I love the directive when it's needed, but I also love having what's already working for me respected, such as yoga, meditation, 12-step, and that being built into the whole
package.
Exactly. That would be what I would say.
Oh, look, thank you, Kirsten and Sophie. Thank you both. I'll come back to you. Don't go away. But I might go to Catherine now and Ash. If you could come on, be great to hear your thoughts and just get a bit, perhaps from you, Catherine, about exposure and exposure therapy as a model. Just
might throw it to Ash, audience. Actually.
Oh, okay, sure.
Sure. So what was the question? What is exposure?
Yes. What is exposure therapy, or what does it look like?
Yeah. So for anyone not familiar, it's a pretty commonly used approach for working with various types of anxiety. And it's basically when you just approach in a graded way a feared stimulus or situation which is being avoided. It might be related to a trauma or a phobia. But the avoidance is kind of keeping the anxiety going. It's perpetuating it. So it's not something, that others may be avoiding. So maybe I'll use the example from the case study, but so my client would be avoiding walking around the suburb, or if she did, she would wear a big hoodie and sunglasses. And that was because she had associations of seeing people that had caused her harm in the past, but that was, a long time ago, and now it's safe. And because she's living in that suburb, it's really disrupting her life. So we might want to, we would want to set up a really systematic and graded way for her to step out and just get used to being in that environment, and basically retrain her body to learn that it's safe and that, no harm is here right now.
Right.
Anyone have
Thank you. And given that we've got not much time and there's a few questions, I might keep going. There's a question here about we've managed to have a whole hour without talking about COVID and the pandemic, so we've done pretty well. But there's an issue here about can you use this kind of therapeutic approach? And does it have to be face to face? Or can you do it via telehealth? And is there a difference? Are you testing that in your research? And there's also a further question about long-term follow-up after 12 sessions. So, starting with, does it need to be face-to-face?
It's a good question. I would say that the broader literature on doing these kind of therapies among adults does show like quite a bit of evidence showing that it can be done via telehealth or video. But when COVID hit for us, and we were undertaking this trial with adolescents, and the adolescents in our study do tend to be still on that more severe end of the spectrum. Like, we're very happy to see people, we were hoping to intervene early if we can, but still, wherever they're at, there. But we were a bit worried when COVID started, more in relation to that other services were shutting down as well. And there was limitations to what people could access and what was available. So we were kind of going back to those earlier stages of what Sophie and Kirsten were saying, of getting people safe. Because for some of them that meant that they were locked down and not able to go out to any of their previous, the few places that they might have felt safe in the world, and were stuck at home perhaps, where they wouldn't have been at risk at the time, but not necessarily a fully psychologically safe space. So we erred on the side of caution in terms of not wanting to do exposure therapy with people when they were in their homes, which may or may not have been safe, that we didn't have control over that environment. But we would like to, and we think it would be feasible potentially down the track to really explore that, and how to do it in a safe way, because the research among adults does show that it is it's as effective as doing it face to face.
Thank you. And do you have a follow-up process in terms of long-term follow-up after the 12 sessions?
Yeah, we have a year follow-up for ours, which is more related to research funding restrictions than anything else. But ideally, we would like to be able to follow people up a lot longer. And we will have, we can have some sort of proxy measures, like being able to look at people's healthcare records and potentially their educational outcomes as well. Like, have they gone on to go to uni? Are they doing TAFE? Did they complete? Or if they're at school, what did they get in their HSC? But ideally, what we would love to see is them in person down the track. And sometimes, even I have to say, in some of the other trials we've done that have not been on these particular treatments, but just more looking at long-term outcomes for people. Like, one study we're doing at the moment is looking at 20-year outcomes for people with heroin dependence that I'd first interviewed in my first job, and they're still around. And it is just amazing to see how well some of them are doing, and all that they've accomplished.
Did you want to comment on that, Ashley?
No, it's all good. I think Kath covered it. Yeah.
Can I ask you both just a question around biological intervention? So you didn't mention this in terms of exclusion criteria for, talked about very kind of acute presentations as an exclusion criteria, but prescription medication, how do you control for that, or identify the role of prescription medication in your RCT?
Do you want me to answer that one, Ash, or you?
Yeah.
Yeah, we measure it. We really didn't want to exclude people for too many reasons. We really wanted to be able to bring in people, as long as it was safe to do so with where they were at. So what we do is measure everything that they're otherwise taking, but we don't want to restrict in any way any other external supports that they may wish to get, or interfere with existing ones. So we, in terms of if they're taking medications, our role would probably be just in relation to being supportive of them continuing to do that in line with their doctor's advice, or their psychiatrist's advice, but not. Yeah, we really don't want to impose on people's ability to get care from. I think, you really highlighted it really well, Kirsten, of there needs to be a lot of holistic things happening for someone. And we can be part of the picture. Part of the picture and part of this chapter for that person, but not the whole thing.
So can I just ask you, there's a question from the audience around Aboriginal young people. So are they included in the trial, and how is cultural safety addressed?
We actually, I don't think any of our clients that we have in this trial are of Aboriginal or Torres Strait Islander background. Ash, correct me if I'm wrong.
I don't think so, and I think you can speak more to this, but I don't know if we can recruit specifically.
We can't target recruitment towards potentially Indigenous client groups, and that's mainly because of the AH and MRC, that there are ethical kind of guidelines that we have to adhere to and get approvals from, and those approvals we looked into them for a number of years around this particular therapy, and worked with people, particularly in the juvenile justice setting, around what would be appropriate, and in the end decided that we think actually for those culturally appropriate reasons it will be better for us to potentially develop something separate, alongside co-designed with Indigenous population that is culturally appropriate. Having said that, no reason to exclude anyone of Indigenous background from the study. Very happy if they come to us and be part of the trial, but we just can't, if they want to, but we can't target that group specifically, or services that are targeted towards Indigenous Australians.
Thanks, Catherine. And I think, this is one of those things with all research where there's like a list of the next research questions and the next studies that come out of this one, one of which is obviously how to think about social and emotional wellbeing for Aboriginal young people and some of these challenges. We've got a couple of minutes to go, and I just wanted to go back to Sophie and Kirsten and just ask you each to make a sort of final wrapping up comment about what you'd like people on this, it's about 70 people on the webinar, what you'd most like them to go away with about co-occurring substance use and trauma. Do you want to start, Sophie?
Yeah, I would say, Kirsten's experience is really so common that there's so much symptom targeting and so little etiological kind of questioning. And so essentially, I think if the best, overarching kind of rule that we always have is not to say to somebody, what's wrong with you, but to actually say what's happening to you. And if you hold that in mind as your number one kind of guiding principle, then, therapy kind of necessarily follows from there.
I would absolutely agree with that. And I also love the focus on attachment. I'm not sure what the term is for it that you would use, but from my understanding, working with building and role modeling healthy relationship skills, that was the most impacted thing for me with long-term childhood trauma. So learning those as an adult is really fundamental to me having a good life. And definitely supportive of anyone in 12-step, because unfortunately there's such a stigma I've heard through all my friends in AA about 12-step in this arena. But yeah, it's really helped me for 21 years to stay clean and sober to even do this work, and being supportive of people who are rainbow LGBTIQA, and just being supportive of people. Exactly, I've got friends who are BIPOC, and any issues that are specific to that being catered for and creating a safe space. So rapport for sure. Thank you,
and thank you so much for your contribution today. Catherine and Ash, would you like to leave people with a particular thought?
I just concur wholeheartedly with what Sophie and Kirsten have said there. I think, sometimes in research trials and things, we definitely come across as a narrow focused thing, but in clinical practice, it absolutely has to be that broader picture about a whole person's life and where they want to go and what they want to do and how they want to get there.
I think that, and I see Ash nodding. We're coming right up to the end. Is there anything you want to add, Ash?
No, just to echo what everyone said, and keeping hope and finding what works for you.
Thank you. And look, thank you all for an amazing presentation. Thank you to people who've come today. Reminding you that you'll be able to get the speakers' email addresses and ask them questions directly. and also see the presentations themselves. That really concludes the first THEMS Learning Live webinar. Thank you to all the speakers and the audience for taking time to prioritise your learning. It's been a terrific set of presentations. All the best to you. And thank you very much again to the 4 speakers and to THEMS for supporting and arranging this webinar. Thanks everyone. See you.